Now it's my honor to introduce you to Courtney Hunter, Vice President of Advocacy at Shatterproof. And thank you, Courtney, for joining us.
Absolutely. Thanks for having me. And thank you to the whole team in Pennsylvania, Kathy and Gina and Donna for inviting me to present and share a little bit today. I am going to talk about advocating for addiction reform and give a little bit of an overview of our priorities and our work on the state and federal level and how everybody can get involved. So I really hope that this can be a conversation and that we can keep it going. We need everybody's voices. So I hope that, after this, we can all keep in touch and you can reach out with questions or concerns. And hi, Denise, I miss you. Okay. So Shatterproof, we are a national nonprofit that was founded in 2012. We're dedicated to reversing the addiction crisis in the United States, and we're working really on quality addiction treatment, having national principles of care for what quality means, working on access issues for coverage, making sure that people can receive evidence-based treatment. And then we're also working on the stigma of addiction and erasing the stigma, sharing people's stories, having a national memorial, and really breaking down those barriers that are making it so difficult for people to seek help and for the families and loved ones of everyone who's struggling with this horrible disease to get the help that they need. And so I don't, really have to spell this out too much for the people on the call. I'm sure you all are aware of what we're dealing with right now, an epidemic within a pandemic. And the scope of the problem has just been exacerbated by COVID-19 and the isolation that people are feeling. Also the economic situation and the economics is really tied to people losing jobs or is always tied to addiction and substance use and also mental illness and mental disorders. So we're seeing, this was from the DEA OD map, we're seeing suspected drug overdoses rose 18% this time over the same time last year. And the CDC actually just came out with numbers last week that showed a 10% increase through March, but that was only through March of 2020. So, I hate to focus on the negative, but I also think it's really important that we all know what's going on right now and that we help sound the alarm, because that's not only my job, but it's everybody's job on this call to say, we need more resources, we need more help. This is not going away. It's actually getting worse. And something that we're also seeing, Wellbeing Trust came out with this estimate of additional deaths of despair. And while this is, the depressing reality, it's also really important to for us to know what we're dealing with and that we can address not only drug overdoses, but alcohol use and deaths from suicide as well, and the co-occurring issues. Something I don't have data for, but that I've just been reading a lot about is this combination of fentanyl in the stimulant supply. And I know this has also been in the news a lot lately, just the increase in meth and cocaine related deaths and how that's contributing to the overall overdoses. So something we want to be cognizant of. This is honestly what keeps me up at night, because we don't have medications for stimulant use disorder. So how are we going about that problem? What's the research? What's the investment look like in treatments for stimulant use disorder? I've talked to so many providers, and it's individualized care, it's therapy. Sometimes, there's substance use, which is really common. So there's also opioid medications for treatment that are given, but nobody has a really good answer. And I feel like I want to keep addressing that every chance I get, because we need to figure this out. If we don't have, some solutions for stimulant use disorder in terms of treatments, that's that's scary. So now that I've set this really grim picture, we do we do have priorities that we're working on. We do have solutions. And there's a lot of reform that needs to happen, but it's possible, and we can absolutely do it. So something that I'm really focused on is payment and payment reform. And I can say that with you wonderful advocates on the phone. I don't like to say the word payment reform when we're talking to insurance companies. Because that kind of shuts the door immediately. But it's really important that a lot of the provisions in the Support Act are actually enforced. So one of those was that every state Medicaid program has to cover all 3 forms of MAT by this year, actually, by 2020. And that's still not happening. So we need to make sure, follow up with those states. Hey, what's going on with methadone coverage? Making sure that they remove those barriers to treatment. And then also, continued enforcement of parity is really important. But other barriers like prior authorization still exist with regard to opioid medications. And then trying to look at this payment in more of an integrated way. And I'm going to talk a little bit more about that in terms of, addiction reform, instead of just focusing on reimbursement, and that will drive quality. Let's have a conversation about integrated care, behavioral health and physical health, and talking about that as one thing from a payment perspective to really sort of change the viewpoint. The other thing that we're really working on is training and education at the national level with credentialing and also licensing. And I'll talk a little bit more about that. And then finally, in terms of our policy priorities, really focused on the opioid litigation. And I know my previous work at Partnership to End Addiction, they're also working on this, which is really good. We need a lot of people at the table to make sure that these dollars are spent in a responsible way. Campaign for Tobacco-Free Kids did this report about the tobacco settlement. I'm sure some of you guys have seen it. Only 2 to 3% of the funds were spent on tobacco prevention and cessation programs, 2 to 3%. And the majority of those funds were literally used to fill potholes. That is egregious. And that could very well happen here. And so we need to sound the alarm. We need to make sure that states are putting advisory boards and advisory councils in place so that there's the right stakeholders. And some states have done this, have passed legislation to put, a 20 group panel of, physicians, treatment professionals, prevention professionals, law enforcement, all the kind of necessary folks in one room to decide what their state needs and where that money should be allocated. I'm very concerned with the state budget, COVID-related shortfalls that we're seeing, that's going to be something that could happen. So with that, stay tuned. Would love to have people involved at the state level with regard to state legislation. This is all going to happen at the states. There's one multi-district litigation, but it's all going to happen at the state level. So your legislators, your elected officials are going to need to hear from constituents and really make sure that the money is spent in a responsible way. So we're hoping to be a watchdog there, and we'll need your voice as well. So also not a new statistic, which this is so amazing to me that this statistic for the last 10 years has been pretty much the same. 1 in 10 people with addiction will ever receive treatment, and even fewer than that will receive any evidence-based treatment. So what do we do here? How are we working to close this treatment gap? Because this is huge. And something I just came across in some of this payment work that I got really jazzed about was that 80% of patients who are trying to get treatment for mental health or substance use are doing so in a primary care setting. So how do we not just give those people referrals, but how do we make sure that there's ongoing clinical support, and that there's care coordination so that someone's invested in that person seeking treatment for behavioral health care. And this got me really excited because I thought, wow, that's a lot of people going to a primary care doctor or, an OB. Like if you're pregnant, you go to the OB, every 4 days. And if you have, an SUD, how are we screening for that? But not only screening and just giving somebody a piece of paper with a referral, which is probably not going to be followed up on, how are we reimbursing providers and incentivizing providers to actually take a vested interest in that patient? So a few other things, I'm going to go back to that, but I want to talk about treatment coverage as well. And this will also not be new to most people on the phone. But, too many families go bankrupt sending their loved ones to treatment. This is the truth. So much of treatment is not covered by insurance. It's even worse, it's not quality treatment. It might not be based on evidence. So we need to regulate the system, but we also need to, incentivize the system to help get more people coverage. And so number of key things that we're working on at the states and continued enforcement of the Parity Act. Incredibly important, but the federal law has no teeth. It's been around for 12 years. It's really important statute, but it doesn't have teeth because insurance is regulated at the state level. So we need each state to pass kind of their own enforcement bill so that consumers really have protections. And if there's a violation or if you're denied treatment for any way, you can actually have some legal standing to go after the insurer. And the most stringent law just passed like last month in California. It was called SB 855. Governor Newsom signed it into law at the end of last month. And this was a huge, huge win. So we've got some legislation. It also broadened all of the protections for people, but also the diagnoses. The law in California was super backdated in terms of what conditions people could seek treatment for, what was deemed medically necessary. And that's been completely updated to align with the DSM-5. So that statute was from, I want to say, the 80s. And a lot of states have similar statutes that just haven't been updated, are not in accordance with federal law. And so that's one thing that we're working on. Of course, the insurance industry fights this really hard. And so this isn't, an easy win, but we have such wonderful partners with the Kennedy Forum and the Steinberg Institute, and a lot of people that are really invested in this. Also helps to have the mental health community and the SUD community be side by side in terms of fighting these battles. So if there's something around Pennsylvania, I will let you know. I've not dug into that yet, or maybe somebody on the phone knows and they can fill me in. But stay tuned for more on parity. And then a few other things in terms of Medicaid, because what I just find so fascinating is that you're more likely to get treatment for SUD if you have Medicaid than if you have private insurance, but it's just not as good coverage. So it sort of doesn't make sense. None of this makes sense, right? But we're working with the commercial industry to get rid of prior authorization requirements. That's still a thing, covering MAT. So that was the provision I talked about in the Support Act. And then this is really sexy stuff, the Medicaid waivers, 1115s. A lot of states have enacted these and have plans, and it gives them extra money and support at the state level to implement what they want to do in terms of expanding treatment, recovery support services, ER handoffs. There's a lot of conversation now around health equity and what that means, and integrated care at the state level. And some state officials through CMS are using their Medicaid waivers to implement good programs. So they're all doing this, in some respect, and they might have their own ideas, but we want to help guide them in the right way so that we're not wasting dollars, so to speak. But there's a lot of, my point is, with regard to treatment coverage, there's a lot of levers at the state's disposal to utilize to help improve coverage. And we're working with them to let them know that these exist. If anybody has questions too, don't feel afraid to jump in. I know Kathy wants it really organized, but I hate just listening to myself, so somebody can interrupt. This is kind of what I was talking about before.
I have a question if you want me to interrupt.
Yeah, yes, please.
So I'll break my own rule. Yeah. So with regards to insurance, and I know this is on another level, but what about dealing with insurance companies when you're trying to have an admission for a non-opioid related admission? Because we've all heard stories of somebody that maybe is using methamphetamines or alcohol, benzos, and opioids. We know are really usually typically the easy ones to get somebody into treatment for. But I've personally heard stories and know of people that actually had to use an opioid on top of their methamphetamine to actually get into a treatment center. So is there any type of policy reform that would help with that?
It's such a good question. And it's something that we raised at the federal level last year because we heard the same thing from people on the ground saying we've been denied treatment for meth use disorder. And they changed the law, the Support Act. So the language, they brought in the language so that it can be any substance. So if you're still being denied, or if you know somebody that's being denied, that's not the current law anymore. And so that's a violation of law if it's a state facility, if they're receiving the state dollars. So the SOR grant dollars, the state opioid response dollars, or any other money through the Support Act, then that's not the case anymore. I can't speak to, private insurance because that's just independently, regulated. So I hope that helps. Cool. Okay. So in terms of payment reform, we're also, I was just saying health equity, but also integrated behavioral health care, this physical health and mental health and substance use. How are we talking about these as one? And one model that's really actually well documented, there's a lot of evidence around it in the mental health space, is the collaborative care model. And this is, it's being utilized in most private insurance. There's about 15 states that cover the collaborative care codes within Medicaid, and we're trying to expand that because it has wonderful, wonderful clinical outcome evidence, amazing, just positive outcomes. There's been like 70 randomized clinical trials around this. And a couple that are specific to opioid use disorder and also alcohol use disorder. And not only are the outcomes better, but there's cost savings too associated with this. So just the more I read about this and the physicians that are actually utilizing collaborative care, the more excited I got about it because it seems like that next step. And so it utilizes three staff in a primary care setting. And this is kind of what I was getting back to before, about 80% of people who are seeking treatment for behavioral health disorder are doing so in the primary care setting. So we're utilizing and helping those primary care providers really feel supported to not only take on these cases, not only know where to send people, but to feel really supported when they're treating, a difficult case, right? Because they don't want to take on those patients necessarily. But a lot of that is they don't feel supported. They're not being reimbursed for their time, right, for treating a behavioral health disorder. And they don't want to screen for this because they don't even know where to send people who screen positive. So these are huge, huge barriers. And it feels like, to me, this is a big entry point to really help a lot of people. So how can we utilize a primary care provider, get a member of the clinical team? So like in a hospital setting, clinical social worker, a nurse can be a PA. And then there's a third party, which is a psychiatric consultant or a specialty addiction provider. And it can be either or, can be both. And this is somebody who just contracts with the hospital. I don't need to get in the weeds on like what the codes look like. You're probably not going to be utilizing the collaborative care codes, but I just want you all to know that this is something that we're working on. We're really excited about because it's a measurement-based care approach, tracks progress, there's really good outcomes. And so could be one of the tools in the toolbox to help us with not only payment reform, but treatment coverage and treatment access. And this is kind of just what I was saying before, my 2 points here at the bottom. We really want to change the way that we view and treat mental health and SUD within the larger healthcare system. So by also training primary care providers to screen and treat addiction, we're helping break down stigma too, because they're looking at this as a disease and not as something on the periphery of healthcare. Ooh, I need to get a consultant for this case. I don't know what to do here. This is outside my scope. But really we need to bring them into the fold so that they can also break down the stigma, right? And this is a white paper that we just created with the Path Forward, which is a mental health entity and kind of collaborative group. And we really looked at how collaborative care was utilized within opioid use disorder and alcohol use disorder, and what kind of evidence we were seeing around that. And as I mentioned, the outcomes were really great. There was a significant number achieving abstinence at 6 months, but also just overall better physical health and better mental health as well. So you might have heard in this space, there's a lot of alternative payment models. What does that mean? How does that differ from what is currently offered in insurance? Because Denise knows me, like insurance, who wants to talk about this? Your eyes glaze over. This is part of the problem and why there hasn't been a lot of change in this specific area, because it's really complicated and it's boring. And so the collaborative care model is not something that gets a lot of people's juices flowing, but it's really important. And if we want to close the treatment gap, we can't only just refer people, but we actually need to invest in them and coordinate their care. And so there's a couple of alternative payment models. I don't love this term because I feel like we're saying there's another alternative instead of this is the way it should be, where we're integrating care and we're also reflecting what quality means, and we're incentivizing quality care and good outcomes. So, there's a lot of talk about the P-COAT model or ARM-APM, which are these different models that look at coordinated care as well, but really incentivizing providers based on their outcomes, having them report how their patients are doing, and then giving them bonus payments or incentive payments for good outcomes, which I think could be good. I'm not a provider, but I also think that if they're performing a service, they should be paid for that, and we should be incentivizing doctors to actually treat these patients, but also for quality. So maybe we need both. And so that's sort of what I'm advocating for, is that, we really need this next step, which is integration, and then let's layer on quality on top of that. But we need to build the bridge first. And that this is the first step, at least in my mind. And so, this all sounds wonderful. Why are states not doing this? They're not doing it because they have no idea that these codes exist. CMS is done. Is there anybody from CMS on the call? CMS has not done a good job of marketing this. Surprise, surprise. They haven't told a lot of people that these exist, that they're not just for psychiatric care, but that they can be utilized for SUD. So we'll talk to states and they'll say, oh, you mean the psychiatric codes? And will say, no, you can use them for substance use disorder. And CMS is actually really clear about that in their guidance. And states will then impose like their own restrictions, like New York State, which is so infuriating to me because it's New York. New York State imposed restrictions on these codes that they can only be used for anxiety and major depressive disorder. And CMS does not say that at all. It can be used for opioid use disorder, it can be used for alcohol use disorder, it can be used for both mental health and SUD. So why are you doing that? Is that a cost saving measure at the state level? Probably. But that limits the care that people have access to. So that's a problem. And so we're working with the state of New York to remove those barriers. So a lot of them are not aware that the codes can be used, and then they're not really resourced. If they're individual practitioners, if they're not within a larger system, they don't maybe have the trained staff on site, and this feels like a huge lift, right? There's startup costs that are associated with integration, and so we're helping states, and would love anybody's involvement on this. As well within your state. Actually, Pennsylvania is one of the states that covers the codes and is doing a really good job. So, but there's 1115 waivers at the state level, as I mentioned before, that they can utilize to help with the startup costs. There's also health homes, Medicaid health homes, and CCBHCs, which are behavioral health centers, or FQHCs too. So those dollars from the federal level can really help with some of this, kind of startup investment. But that's a big undertaking. So it's going to take multiple partners at a state level or even a regional level to get something like this started. Penn in Pennsylvania is doing an amazing job. I spoke with a primary care physician there a couple of weeks ago who said, a year ago, he was terrified to take these cases because he just did not feel supported. And now he's in a whole different place and he feels like an expert. And that's a big difference in terms of getting people, not only that referral, but getting them better outcomes, getting into the right treatment and closing that gap. So, the other thing that we're really concerned about is treatment capacity, just having the healthcare professionals that are actually trained to provide addiction care and treatment, and prescribe the necessary, medication too. So this has been kind of an ongoing, issue in our field. Is we need more people who are aware of addiction treatment and are trained in that. But so we need the primary care piece, and we also need better specialty care and more people in the field. Like there's just a shortage of people that are in this field. We hear it all the time. And insurance will say, oh, well, we have network adequacy issues, right? Like we just don't have the number of people. And we'd love to be able to fight back against that from an insurance standpoint and say, we do have the network, and here are the number of people that are trained, or here are the number of, credible facilities, et cetera. So the other thing with regard to training is the buprenorphine waiver, the X waiver. We're working to remove that. There's only 4 to 6% of all medical professionals that are currently waived, and only half of those are actually utilizing the waiver and prescribing buprenorphine. So that's 3% of healthcare professionals. That's abysmal, and we need to change that. So I would be happy if we remove the waiver completely. France removed their waiver actually don't know the time frame, but it was a while ago, and their overdose deaths fell by 79% when they did that, when they got people on medication. So we've seen this work in other places. We need to do this. And if we don't remove the waiver, another solution is getting all medical professionals, so not just physicians, but PAs and NPs, anybody who has a DEA prescribing license, to get them a waiver training and just demand that they do it in medical school or in residency in training. And two other things really exciting about telehealth. We've seen no-show rates for mental health and SUD appointments decreased, which is awesome. So more people are going to treatment. There's less stigma associated with telehealth. So we're working, at the state and the federal level to make sure that these COVID-related restrictions remain permanent. There's no reason that we can't have a telehealth visit for, buprenorphine initiation, but you can have it for, a pain appointment and, get Oxycontin. I mean, that's insane. So the one that is still bothersome to me and we're working on is methadone initiation. And having to go into a methadone clinic every day to receive your medication is incredibly impossible in a pandemic. And so how do we get around that? And the federal government still feels like there's some diversion and some risk with methadone because it's a pain med. But it's also a treatment. And so we really are working with ASAM and a few other groups to make sure that people can get methadone prescribed in a remote setting. So more to come on that. Would love your voice on that as well. And then, improving reimbursement rates. That's always going to be out there. Because the more we incentivize people to go into this field, the better treatment providers we're going to have and the more access we're going to have. So these are two pieces of federal legislation that I was just mentioning on addiction training and education. So one is this is just what I was citing here about the 79% decline in overdoses in France. So that's the Mainstreaming Addiction Treatment Act. And then the Medication Access and Training Expansion Act would require physicians, not just doctors, actually anyone with a license to prescribe controlled substances to receive addiction training. So I actually have Senate Companion introduced this week, but I believe it was 2 weeks ago now. And that's very exciting. That's moving along. We're hopeful that in a lame duck session, nothing's going to happen for the election. It's not going to happen. We might see a COVID stimulus, but probably not. But who knows? I'm not Nancy Pelosi, but we might see something in the lame duck with regard to MATE. And so MATE, the MATE Act is a lot more people are pushing for that because it's less controversial. But I would be happy with both or the MATE Act. So. Oh my God, I've talked so much. Okay, so I just want to say it's really important for everybody to weigh in, state and federal officials, whether it's on, Partnership to End Addiction has awesome action alerts about the Family Support Services Act, which just passed the House, or any of this other key addiction legislation that I mentioned, the MATE Act. We are going to do a push for that in the lame duck because that has a chance. And so it's really important for people to weigh in. I always say this to advocates, to ambassadors, to people on the ground. Staffers in office have to count how many times they receive an email, a phone call about a certain piece of legislation, about a certain issue. And so it really, really matters because if they say, oh my gosh, we have 500 calls today or 500 emails for this one bill in Pennsylvania, people really care about this and they have to respond. And I really think it's important to tweet because that's, public. And so if you, tag your elected official, it's out there and they're more likely to respond. So it's, do your duty and weigh in because it really does matter. I think that's all I have. We have an advocacy toolkit here. And then I have my email address and I'd love to answer questions or, just have a conversation, and just so grateful for everybody at Drug Free Workplace PA for all the awesome work you do. And, I hope we get to partner and work together.